oncology product is range from 80 to 100 a year, 80 to 100,000 a year for the treatment course, and we have to consider that that patient would also require to be hospitalized, and that itself can add up to be extremely expensive. Hospitalization actually is the number one most number one pricey part of the healthcare. So, but if the treatment is so effective that you actually reduce hospitalization by half or more than half, you basically reduce the hospitalization cost by half, and that actually is a long-term cost saving. And so we need to put that into consideration. And so if this is non-steroid based and it is highly effective, more than 60%, and and we can look back to the trial and look at number of hospitalization, compare that with historical control, and see if hospitalization is also reduced more than 60% or so, then I think it's justifiable for the high cost. Because I think if we to look at the historical cost and using non-effective therapy, and those non-effective therapy is not so cheap either. On top of multiple hospitalization, they actually add up more than 80,000 a year. And so I think pricing 80,000 is reasonable, and because compared that across the board is not tremendously high number. It's pretty much a comparable number, but at the same time, if the hospitalization and other non-treatment related costs add up, I think it's often sound very reasonable from a P&T perspective.
Okay. Can you help wrapping up here? But it'd be interesting if you can think of any other therapies that are administered within the hospital setting only, either in this patient population or another, that are in that price range, and which perhaps have the same potential effect. They're life-saving in a specific population. It's not a large population, but where the cost of the drug is borne by the hospital, and then a reimbursement is achieved afterwards. Any other drugs that this sounds like that I could look at?
I think all the novel IV drugs, that's formulary, like Opdivo, that's the PD-1 inhibitor. Daratumumab, CD38, that's the CD38 inhibitor for multiple myeloma. And I think these are two big ones that I can remember, which drastically improve efficacy and reduce the disease-related complications. And I think overall, I think the cost effectiveness analysis would give us a better picture.
So, well, I appreciate your perspective on this, and I will tell you that truly for such small patient populations, it's often necessary to charge this amount of money in order to produce a business, for lack of a better word, that's viable and results in the completed development for the therapy. And I do believe that's likely the case in this situation. Well, thank you very much. Do you have any other questions or any other things that you think you'd like to share with us about this opportunity?
Oh, no, I think we covered in great detail. Thank you. Very
good. Well, I'm very appreciative of your time this morning, Dr. Yan. I would like to just say that hopefully we will be able to get thoroughly involved here and bring a therapy that meets this profile and would be useful to your patients. And if we're able to do that, then we will certainly reach out and speak with you further. So I look forward to the possibility of that and making proper introductions. Thank you for your time this morning.
Thank you. Bye-bye.
Take care. Bye-bye.